So types of technique charts, we have essentially 5, and fundamentally you just don't see technique charts, physical technique charts. We used to have a binder in every room that gave us a measurement and set the KVP in the mass, gave us the KVP in the mass that we needed to use for each one of those measurements. So if somebody mentions measuring the patient thickness with calipers, or if you've read that in any kind of book, that's what it's referring to. And we've, I think, especially with CR and now especially DR, with the computer algorithm kind of ferreting out the contrast and density, I think that they've become more rare, and especially with using automatic exposure control, that portion is even more rare. So with automatic exposure control, pretty much all you got to know is the KVP for that specific part, right? And that's kind of built into the system with what we refer to as anatomically programmed radiography. I got in parentheses automatically programmed radiography because it's kind of one and the same. You push a button that says chest x-ray and it sets you up for a chest x-ray automatically, right? So I've heard it referred to both ways. Probably anatomically programmed radiography is more common, but automatically as well. So what we have then are variable KVP charts, fixed KVP charts, high KVP charts, automatic exposure control, which really plays into all of those unless you're doing a tabletop technique, and then you've got your anatomically programmed radiography. So variable KVP suggests just that. And I've got underneath that contrast issues with a question mark. Okay, so you teach something a certain way for a long, long time, and a whole lot of people hear something for a long, long time, and they have a hard time getting away from it, right? So KVP controls contrast?
No.
No, but you might hear it from somebody. So in that same vein, what you may hear is the variable KVP charts or the type of technique chart that would affect contrast. Okay, and the reason it does is because you use just enough KVP to penetrate, and then you don't use any higher KVP. The mass is relatively set. So if you use just enough to penetrate, what controls penetration? KVP, right. So the lower the KVP, what's your contrast look like? Lower KVP, you get less differential, or I'm sorry, more differential absorption, and you get more blacks and whites, so it turns out very high contrast. So in that way, long ago, variable KVP charts were a high contrast KVP chart. The more common between variable KVP and fixed KVP would be, I'm sorry, between those two would be the fixed KVP. And you even see that in phototiming. You know, if you're doing a chest x-ray, PA chest x-ray, what's your KVP? 110, 110, 120? Anybody going above 120? No?
105.
Yeah, 105. Okay, so is that pretty consistent across populations? Unless you're doing pediatric patients, tabletop, portables, in the department, you hit chest x-ray, and you're probably getting that, right? So then what happens if you're phototiming and you use 110 KVP on an asthenic patient versus a hypersthenic patient? What changes? You use the exact same KVP.
Amount of tissue.
The amount of tissue that you're going to penetrate, right? So the amount of tissue that you're going to penetrate, and the amount of the x-ray being the hypersthenic patient's going to attenuate. So you're phototiming, and there's your key, what's going to happen?
It's just going to be a longer exposure.
Longer exposure giving you a higher overall mass, right? So with a variable KVP, what you have is a relatively fixed mass value. With fixed KVP, the mass fluctuates. High KVP is where we're going to use, what we're going to use on structures that have very high natural subject contrast, like chest x-ray, and we don't want that contrast. If we're shooting ribs, we want that contrast, and we might not use as high KVP, even though KVP does a really control your contrast, you're still going to see that. You know, if you took a chest x-ray with 110 kVp and you process that chest x-ray under a rib algorithm, it's going to look like ribs, right? But still, we use low kVp on ribs. Probably shouldn't, but we do. All right, so high contrast structures where we don't want to see high contrast, really chest x-ray, we're going to use high kVp. But also for barium work, we're going to use high kVp. For iodinated contrast studies, we still use a higher kVp than what we normally would have, but it's not going to be as high as barium. Barium is really, really hard to penetrate. So I think I've said this before, if you go to clinicals and you want to see how hard it is to penetrate barium, just take a thing of barium. You don't have to pour it out, you just take the little jar of barium, lay it on the table, make an x-ray of it, centering directly on it, and see what kind of penetration you get through that barium. It's not going to be good. All right, so we have to have high kVp to penetrate some of it. The thinner portions, the thicker portions, you're probably still not going to penetrate. Then we've got AECs. AECs, remember, are just your phototimers. We have two different types. You got the ionization chamber and whatever, but they all work the same. And it's just a photon counter, and it terminates the exposure whenever it receives a proper amount of radiation. If you're using more than one, then they have to kind of work in concert with each other in order to get the right exposure. So again, you've got probably a fixed kVp and it adjusts your mass. Okay, so do you really have a physical chart for AECs? Not in the traditional sense where you would need to know kVp and mass. And then anatomically programmed radiography is built into the system. That's not why, in large part, why you're not seeing the binders anymore that are full of techniques is because it's built into the system. You push chest x-ray and it's going to select your kVp, it's going to select your MA, it's going to select your focal spot size, it's going to select your cells. It does everything for you, right? So providing you select the right one and you position properly, you should get a decent x-ray. So those are really your most common types, or really the types of technique charts. When I say fixed kVp, that is considering all of this down here. Really, if you consider everything that the machine sets up, anatomically programmed radiography is the most common on new equipment, right? But it does not invalidate that it's still a fixed kVp chart. Does that kind of make sense?
Yeah.
All right, so automatic exposures, you know what that is. That is, you're using your AECs to set your mass. You got your kVp, you set an MA, and this really controls the time. So positioning has to be very accurate. I've worked in hospitals that wanted to rely on AECs almost universally, and I've worked in hospitals who hated AECs unless they absolutely had to use them. Fluoroscopy, barium work, things like that. So you had to memorize your technique, and there's benefits to both of those. With AECs, your positioning has to be pretty precise. So we talked about last semester, for example, if you're taking an x-ray on a humerus, you've got a relatively, it's going to be a little bit bigger than this than most people, but you've got a relatively small bone inside of a, fairly large structure, and what do you want to see? You'll see the bone, right? So the bone needs to be positioned directly over the AEC, and the AEC may be, it's probably stretching it a little bit, but that big. So are you going to be able to completely cover the AEC with the anatomy of interest? The answer is no. Will the rest of the upper arm compensate a little bit for that? And the answer is yes. But now, what if you've got a situation where you perfectly position the anatomy over the AEC, but the anatomy, the skin level is here and here with the bone there, and this is the size of your AEC. Can you see that line? Let me make the line green and big so you can see it a little bit better. So what if your AEC is that big and your entire anatomy is skin line bone? What are you getting to the AEC? Direct exposure. So what's going to happen with it? It's going to shut off really fast. So positioning has to be precise and the AEC has to be completely covered or you're going to run into some issues, right? So positioning, absolutely essential. Good positioning is absolutely essential with good automatic exposure techniques. If you're setting manual techniques, you got some latitude in your positioning. You know, you can off center, you know, this is not an issue at that point, right? Because you set your technique and you're not dependent on your automatic exposures. So you can use, you know, different orientations of radiation detectors. I used to work in a hospital that, you know, our processing used water. They came into the system, they didn't control the temperature of the water. In summertime, we had to use less radiation than in the wintertime because in the summertime the water was hotter than what it was in the wintertime. So anyway, it's kind of complicated. So what we had to do if we were going to phototime something like a chest x-ray is in the wintertime when the water was colder and our films would come out light, we'd use all 3 cells for chest x-ray. Now why all 3 cells? Well, in the wintertime we'd just use outer cells. But what would the center cell be receiving radiation from? Mediastinum, going through the heart, the great vessels, it's going to take longer to shut off in wintertime. So I walked through that to tell you that you can use a different orientation to give you different exposures. Okay, so you know, if you got a patient that you know had a pneumectomy on one side and you're shooting a chest x-ray on the patient, then you might just want to use the 1 cell over the lung because that other side's, you know, the lung's gone and that's just going to fill in with fatty tissue. So if you use both of those cells, what may happen is you overexpose a patient, right? So again, automatic exposure, usually fixed KVP, and then automatically or anatomically programmed radiography. Tomography, we're not going to spend a whole lot of time on this, but if you have aspirations to go to CT after you get out of X-ray school, CT is kind of this. And what CT does is, let's see, I find the center of this is roughly right there. Okay, so CT, what CT does is it takes the concept of tomography and it takes it to an extreme and attaches it to a computer so that you can do some reconstruction. But you know that motion is the #1 thing that will destroy an image, right? And it's the main thing you don't have any control over. But we can use motion to our benefit, right? So breathing techniques, when we do breathing techniques, we use motion for our benefit. And that's what tomography is. Sometimes you'll hear things like breathing techniques, wagging jaw, and things like that referred to as autotomo. Okay, so that's a patient providing the motion. But with tomography, what we had, and with CT is what we have is motion of the image receptor in the X-ray tube. Now, knowing what you know about motion, the more motion you have, the blurrier the image is going to be, right? So with tomography, what we would do is we would put the patient's anatomy of interest right at the pivot point, right dead square in the middle between the X-ray tube and the image receptor, so that as we moved anything further away from this pivot point, what we call the fulcrum, would blur out more than what's right there. Does that kind of make sense? Okay, that's basically what they do in CT as well, just a little bit more complicated, but that's the foundation for CT is using motion to desuperimpose that thing, those structures, and then using CT to reconstruct it so it looks like we've taken the patient, cut them in half, and we're looking at the bottom side of it. So, you know, the only one that we actually might use anymore is panographic or panoramic tomography. Anybody have I just lost the name of it. the thing that goes around your head you get in the dentist's office that gives you an image of the jaw and your teeth. Panorex. No? Nobody has that in the ER anymore? Okay.
Oh, no, not in the ER.
Okay. So you'll see it in the dentist's office, but also when we get into facial bones, we'll talk about it. It rotates around the patient's head. So you've got the image receptor on one side and the x-ray tube on the other side, and it rotates around the patient's head and keeps the jaw in focus, and it uses the same principle. Blur out anything that's out of the focal plane so that you can see the anatomy of interest a lot better. So you might at some time in your career see a Panorex. It used to be in every ER. I guess they just send everybody CT now. All right, so magnification. We got a couple of things to consider on magnification. You know all the stuff that magnification causes: size distortion, increase in magnification, increases unsharpness. Don't confuse just straight magnification with air gap. So those are two totally different things. Air gap we're going to talk about when we get into grids. That's intentional magnification, or it's not intentional magnification, I'm sorry. It's increase in OID, and we say we use the air gap, but it's really because of normal anatomy. And what happens is some of the X-ray photons miss the image receptor, and thereby, it cleans up scatter radiation, right? So where we get magnification is if we decrease SID or we increase OID, then consider SOD. We'll talk about SOD later in the semester. But either one of those is going to increase magnification, decrease sharpness, or reported detail. So if we have a natural increase in OID, we can overcome that with an increase in SID. All right, so this is not going to be on this test, but just for your understanding, kind of a primer for next semester, it's kind of a ratio type thing. If you let's say you have a set SID and you have a set OID, if you double the OID, then you can overcome every bit of the magnification that you introduced by doubling the OID by doubling the SID. Okay, so it's a one-for-one type thing. So what things are going to cause magnification? Natural anatomy, right? You can't do a good lateral C-spine and expect to get C7T1 if you put the image receptor all the way up against somebody's neck. You got to put it down on the shoulder, so you have a natural increase in OID. Chest X-ray, if you consider the heart to be your primary thing of interest, then you're going to have, at least on the upper end of the heart, you're going to have an increase in OID. So natural anatomy for the most part. But there are some other things as well, body habitus. So back to the tomography thing, the place that we used it in my career the most was on IVPs, when we used to do IVPs. So the kidneys lay 1/3 of the way through the patient's body. So we'd have to take calipers and measure the patient's body, and just to keep it simple, let's say the patient measured 21 centimeters from back to front. That means the kidneys being 1/3 of the way through, the kidneys, if we wanted to get a tomo image of the kidneys, then where would I set my fulcrum? 21 divided by 3 would be 7 centimeters, right? So we'd measure 7 centimeters, we'd set it at 7 centimeters. Okay, so now the patient weighs, or I'm sorry, the patient doesn't weigh, but the patient measures 35 centimeters. Where would you put it now? Or let's even make it extreme. They measure 49 centimeters. Where would you put it now? No. I'm confusing my numbers. Let's say the patient measures 33 centimeters. Make it easy. Where? 11. Right. So forget all the other numbers. It's 1/3 of the way through. So if we have a hypersthenic patient, then it's naturally going to increase OID. And I'll give you a practical example of how that played out one time. Again, it was IVP. And since we just came through contrast studies, this is kind of applicable if you ever find yourself in a situation where you're having to do IVPs. Take a look at everything. Don't just be a button pusher. Take a look at everything. So you do your scout image, and what you're going to see on the scout image is you're going to see the spine. I've not ever done this before, so I don't know how this is going to work out. But let's say you've got the spine, but what's directly in front of the spine? Okay, in the upper end, you got the esophagus. Let's think a little bit lower down, let's say into the abdomen. Two great big vessels. Yeah, you got descending abdominal aorta, and you've got the inferior vena cava. Okay, so the vena cava is not really the issue here, but the abdominal aorta is. So abdominal aorta is just in front of it. So for the most part, the liver is going to completely cover it up, right? Even on hypersthenic patients, it's going to completely cover it up. If you happen to see the abdominal aorta, let's say you're looking and you're looking at your scout image and you kind of see the kidneys and you see the bladder, you know where you need to center. You see the vertebra and you got something sticking out on both sides of the vertebra. Very few things that could be. Maybe the patient has a mass right at midline, but they could have a bulge in that aorta. What do we call that? That's an aneurysm. Okay, now you inject 100 cc, you increase their blood volume by 100 cc's and they've got this massive aneurysm. What might happen to the patient?
My first.
Yeah, and they're done, right? You can't get them to surgery fast enough. They've got a massive aneurysm. So anyway, to tie this all back to how, the patient size, this guy was a big guy. And, the image fell out. And I looked at it and said, this can't be what I think it is, because aneurysms, the body adds calcium to the aneurysm to strengthen it, right? So this thing had almost no calcium. So this can't be what I think it is. So take it back to a radiologist. I say, what do you see here? And he said, do not, under any circumstances, inject this patient. I'm going to take them over to CT. I'll inject them slowly, and we'll take a look. He said, I don't think this is as significant as what it looks like, because he's a hypersthenic patient, he's a big guy. So we took him over CT, did a limited study CT with limited contrast, slowly injecting, and he was in surgery the following day at the other hospital. It was such a dangerous situation. Had we injected this patient, who would have popped. So what's the point to that? Well, the doc thought that the patient's size was giving us abnormal magnification where it was not, but it can, right? So we can get magnification in body habitus, body thickness, body position, object shape. Object shape, can I borrow your water bottle for just a second? All right, so how do we minimize OID? All right, yeah, minimize OID.
Put it closer.
Put it closer,
Yeah.
right? So if we have anatomy that has a thick end and a thin end, how could, let's say something is triangular in shape, how would we minimize magnification?
Put it on the
Put the fat end closest to the image receptor. So now we got this thing. Am I going to get more magnification like this or like this? Like this, right? So back to the water bottle. What's its shape? I'm glad the lid was on. What's its shape?
Cylindrical.
Cylindrical, right. Cylindrical, if it was two-dimensional, we would call that round.
Yeah.
Or if it was three-dimensional and it was round all the way around, that would be spherical. So any of those, how do I get the fattest part of that closest to the image receptor? You don't.
Yeah.
You don't. So you're always going to have an increase in OID with something that's round, cylindrical, or spherical. Okay, so what did we just come through? Positioning. What did we spend Monday talking about? the most cylindrical, round, spherical looking thing that we've got, right? So, you know, you're gonna have some distortion, some magnification on anything that's round, cylindrical, or spherical. Okay, so now the reason I brought up air gap is because we have a tendency to kind of conflate magnification with air gap technique. All right, so air gap technique is, I don't really want to say a theoretical thing, but it's a consequence of an increase in OID. When we have an increase in OID and we're taking advantage of the air gap, we want to increase SID to overcome magnification, right? As opposed to magnification radiography, which is macroradiography, we have an increase in OID, has nothing to do with the air gap. We want the magnification, so we do not increase the SID. It's intentional magnification radiography. And where we use that sometimes is, I think we've talked about this before, is in special procedures, things like that, right? And it's really because we have digital magnification now. It's really more for convenience than anything else, but because we have that increase in OID without an increase in SID, macroradiography, then we're going to lose some sharpness of recorded detail. So how do we reintroduce some of the sharpness of recorded detail? Well, mammo tubes use a fractional focal spot. We use a smaller focal spot so that we don't completely lose our sharpness recorded detail. So know the factors in your magnification factor. What is SOD? Source to object distance. So how do you find source to object distance? Subtract OID from the SID. I think you were going backwards with it, but yeah, you're going to wind up in negative numbers there. But subtract OID from SID, that gives you SOD. Okay, so you're not going to have to work this on this test. We'll get into that next semester, and I'm going to tell you that most of the time that people miss the question for magnification factor when we're using this formula is they'll go SID over OID. They'll forget to calculate SOD. Okay, so lock that in for the fall semester when we go back into this, and don't make that mistake. Okay? Any questions on the rest of that?
So on slide 58, it has like the factors and it's controlled by. It says
61.
contrast.
It's 61.
Oh,
61, okay.
It
Okay.
says contrast and this says KBP.
You know what? No, it doesn't. Any other questions?
So, was that whole table wrong?
Oh,
Because I did put that in my notes.
no. Optical density is not affected by that. Let me try this. Let's just do this. Can we? It's kind of funny. You might not have thought it was funny. Paste. Let's see.
I don't know what you're talking
Yeah. Nothing to see here. Oh, that's not what I wanted either. I want to delete cells. You know what? Let's just do this until I don't want to lose time to. Oh, well, there we go. That'll work. All right. You know what? Let's, instead of doing that, let's go with lookup table. This contrast density is still applicable. It's just how we get to it is really different now. Okay, so let's make that adjustment instead.
So now just